Any areas of synovial fibrillation or synovitis can be ablated with a lower setting of the laser. Areas of cartilage debris and fibrous adhesions can be ablated simultaneously. Occasionally, attempts are made for the anterior capsular release from within the body of the anterior band of the disc. This eliminates some of the hemorrhaging, which can occur when cutting into the pterygoid muscle. Fibers of the pterygoid insertions which have been cut through a portion of the disc laterally and anteriorly, resulting in a good release. Small vessels and even bleeders can easily be coagulated with the Ho-YAG laser by reducing the pulse energy level to 0.8 joules at 10 times per second. The laser has enough thermal effect for hemostatic purposes without charring of the surrounding tissues. Partial synovectomies can also be accomplished with these same settings, and smaller vessels and inflammatory conditions of the synovium can easily be reduced as well. This laser blanches and shrinks inflamed synovium by desiccation and capillary coagulation, as well as effects on type 2 collagen. It has a significant advantage over mechanical synovectomy, which creates considerable bleeding and tissue shredding and requires electrocoagulation as an adjunct. Post-operatively, the patients seem to have minimal pain and edema and seem to have healed better than those who underwent surgery with mechanical instrumentation. The laser is being used in an oblique fashion to reduce the inflamed and proliferative synovium of the retrodiscal area and creeping synovitis of the displaced disc. Additionally, the redundancy of the posterior attachment tissue is reduced with the same laser settings. The retrodiscal bilaminar zone is reduced using the laser with a slightly higher setting and at an oblique angle resulting in a large spot size. Next, this patient exhibits lateral impingement syndrome with a hypertrophic tubercle and osteophyte along the lateral aspect of the eminentia. When an eminoplasty is performed with the Ho-YAG laser, studies have shown that thermal damage to adjacent bone is limited to 130 to 220 micrometers, and the post-operative healing is approximately 7 weeks. The tubercle is reduced layer by layer using a paintbrush-type motion. You should see a horizontal guide groove being cut into the eminentia at the onset of the procedure, giving a guide to the surgeon of what level to approach. After an adequate amount of bone is removed, the residual area is usually quite rough, and this needs to be smoothed percutaneously by a miniature rasp via the anterior portal with a motorized instrument. It is imperative to have already accomplished a lateral eminentia release and capsular stretch procedure prior to this eminoplasty technique. Occasionally, this technique requires the use of the joint spreader, which was originally designed for arthroscopic use with percutaneous applications. In most cases, the simple distension of the joint following release and manual manipulation by the assistant allows adequate access for these minor eminoplasties and osteophyte removals. As we mentioned before, following reduction there is a roughened surface of the bone tubercle, and necessity for smoothing with a reciprocating file and rasp is evident. Following filing with a reciprocating rasp, the glassy smooth finish is checked with a right-angle probe. Next, this patient presented with limited range of motion, with an interincisal opening of 31 millimeters. The initial clinical impression was fibrous ankylosis of the temporomandibular joint. However, during the arthroscopic procedure, a bony bridge between the superior and medial aspect of the condylar head and the fossa was noted. Using the Ho-YAG laser, the bony bridge was removed layer by layer. Most of the bony ankylosis was located in the medial trough and superior region of the superior joint compartment. Through the superior lateral portal, adequate access to the medial region was achieved. A right-angled probe was used to evaluate the medial trough. The ankylosed bony bridge was eventually debrided, and the condylar head was freed from the fossa. A reciprocating miniature rasp was used to file away bony irregularities on the condylar head. The condyle that is shown here was eventually freed from the medial fossa after an adequate amount of bony bridge was removed. This technique of arthroscopic laser debridement should only be performed in selected cases when bony ankylosis of the temporomandibular joint is partial in nature, with the remaining structural anatomy intact. Other procedures that can be accomplished with a Ho-YAG laser include debridement of perforations and chondroplasties. In patients with a grade 2 to 3 chondromalacia, the Ho-YAG laser can be used to contour the base of the chondromalatic cartilage to a less friable condition. The risk of small cartilaginous fragments breaking off and irritating the joint lining is reduced due to the laser's ability to fuse the tissue. Areas of perforations with proliferative granulation tissue can be cleaned, reduced, and smoothed. Another patient exhibits more advanced chondromalacia with fibrous adhesions and pseudowall formation. The probe is used first in determining the extent of disease, then utilization of the laser is maximized.